Good afternoon, everyone. We are going to go ahead and get started with our journal club. And today we want to talk, I'm Dr. Diane Sanders-Cepeda, and we want to talk about meeting the current clinical challenges in post-acute long-term care. It's going to be an interesting session. I want to do much more listening and talking with some of our state leaders than actually presenting. And who we have on our list today, you may have already heard Kim Smoak is here, and she's like amazing always. And then at the bottom of the hour, we're going to be joined by Dr. Kenneth Scheppke. So a lot of things that we need to talk about and unpack. I want to start first, just looking at where we are at, and I'm going to go to this slide first. So looking at where we're at as far as what we're going to address today, a lot of heavy lifting, because if you recall at the end of February, I think it was the end of February, there was a State of the Union address by President Biden. And for the first time ever, I don't know if it's true for the first time ever, but for the first time I've ever heard, nursing homes were mentioned. So we want to really look at some of those policies and then think about what we need to do to become prepared for an endemic standard, an endemic way of life as we look at how we are moving with COVID and living with COVID. I will say that if we are looking at what's happening now, there's a lot of positive news. As of March 25th, in the state of Florida, our positivity rate was only 2.3%, which is amazing. This graphic is from today, and this shows that the United States is at a 3.73% moving 7-day average for positivity rate, and that's really good news. I know we're hearing a lot about the new variant that it has been in the news, the BA.2, which is an Omicron variant, so a variant of a variant. And we are seeing that in certain pockets throughout the country, a lot of that in other countries as well. But within our country, there are things that are happening with us looking at the wastewater surveillance, try to predict where and really look at where we're going to see those outbreaks. So we're nowhere where we were, I guess, in the summer of last year, and we're even better than what we were a few months ago. And I think that every time we learn, the interesting thing is that on yesterday, we did see that there was a second booster that was authorized by the FDA. And this is really targeting those individuals who are 50 or older or who are immunocompromised. So, I think as we are looking at what's happening and everything that settles, I feel comfortable saying that we need to learn how to live with this. This is something that is that will enter into endemic, where we're going to still see these hyper-local events that we've been seeing all throughout the pandemic. It will continue to impact our facilities, and we need to prepare ourselves and our infrastructure to really deal with that. What was interesting, though, and to the comments I made earlier, is that we saw for like I said, my first time in listening to a State of the Union, nursing homes being mentioned. Now, anyone who knows, anyone who's ever tuned in, anyone who's ever seen a presentation, how I feel about politics. Is like the least favorite thing. I don't ever want to talk about it. I love strategic planning, and I love policy, and I love making action plans and contingency plans, and I could do that all day because I am a medical director. But the politics of it all, I don't like. But it was interesting hearing about these priorities, and I put up the 5 key priorities. The first one is ensuring taxpayer dollars support nursing homes that provide safe, adequate, and dignified care. And the components of that really are around establishing a minimum nursing home staffing requirement, reducing resident room crowding, strengthening the skilled nursing facility value-based purchase program, and reinforcing safeguards against unnecessary medications and treatments. The next was around enhancing accountability and oversight. And this is something that we really, as leaders in post-acute long-term care, need to really think about. There was statements around beefing up scrutiny on more of the poorest performing nursing facilities, and adequately funding inspection activities, and expanding financial penalties and other enforcement sanctions. There was comments around increasing transparency, which is creating a database for nursing home owners and operators. And then we also saw statements around creating pathways to good paying jobs with free and fair choice to join a union, ensuring our nursing aides training is affordable, launching national nursing career pathways, and then ensuring pandemic and emergency preparedness in nursing homes was really the fifth key priority. And that involved looking at how do we strip the requirements for on-site infection preventionists, enhancing requirements for pandemic and emergency preparedness, and those things. And so when you hear it, I think in the speech, certain things sounded really positive, but we really had to look into the details and understand this. And the first statement that we saw really come through was from ACA and NCAL, the National Organization for Assisted Living. And it was interesting, and I'll just point this out, that assisted living wasn't highlighted, and that is something that I think everyone who works in the post-acute long-term care continuum needs to think about as well. We have to be very careful when we're hearing that more scrutiny, regulations, and fines are coming our way. And I think both ACA, NCAL, and AMDA, both in their responses, all three of their responses to this, really stated the same thing, that while we appreciate certain aspects of these policies, what does this mean for our facilities, and how do we really move forward? And that is what I want to talk to Kim Smoak about. So Kim, I don't know if you're ready to come off mute, but I want to really, and I'm gonna want to really maybe get your perspective and just have you say a couple of things first, so that we can hear what you thought about some of those policy changes and addressing those staffing challenges.
Well, I mean, I will say, and I know that, and I mentioned this at FAEMS last week when I was speaking, I agree. I think that, kind of back up a little bit, I think that we all knew, although maybe not at this level, I think we all knew that prior to the pandemic, we were coming up on a staffing crisis in our healthcare industry alone, globally. I think that the pandemic, I think we all have seen that the pandemic has just, kind of lit it on fire, so to speak. So now we're having to deal with, the staffing challenges that are out there. But just so that everybody understands, the staffing challenges that we are facing in our healthcare industry, in hospitals and nursing homes and assisted living facilities, and anything that in which care is being provided. We also, at state survey agencies, and I'm not speaking about Florida, but I mean nationwide, because I know a lot of you have nationwide companies, a lot of you medical directors are, a part of national organizations, so you may be hearing it too. We are also, as state survey agencies, those about, that are regulators that are coming into these facilities that are charged with making sure facilities are following the regulatory requirements in order to continue to operate. We are also, experiencing our own staffing challenges as well. So we're kind of, this is one of those things, I always talk a lot about, we really are in this together, and we really are. This is one of those that we can truly say we are all working on this together, and that, it really impacts both sides essentially. Although we're one big old team, maybe have disagreements as far as how things are implemented, but we are also facing the same things many providers are, with with staffing challenges. So I do know, many of you may be aware, and, Florida Healthcare Association, who I believe we have some representation on from today, Kristen Knapp, I'll call Kristen Knapp out, and Debbie Franklin, they worked together and actually presented, I believe, last week on the Florida Healthcare Association, the workforce grant that was approved. And, I'm not going to steal any thunder away from them. It is something that they are working on as well. And so have shared, what they've been doing since this grant was approved. And that's one of the reasons why I provided information to FDANA. And I know that Ian and the Florida medical directors are also have a grant approved as well. The civil monetary penalties, and what I'm talking about, folks who may not know, we do, for civil monetary penalties that are imposed against nursing homes, nursing homes have to pay that fine within a certain period of time. All that goes to the Centers for Medicare and Medicaid Services. A portion of that, so the Medicaid portion of that, comes back to us, to the state of Florida, and this is for any state. So that is the funds that we have available to approve projects that improve quality of care, quality of life in our nursing home, that do studies like this on staffing strategies. And I know Ian and their and also organization has one of our grants approved as well. I don't have them all of them in my head, but the grants cannot be used for capital improvement. So we cannot approve a grant to paint your nursing home. We can't do that. But wouldn't that be nice if we could? But we can't do that. But those are really some neat initiatives that we do have. And one of them, like I said, is it's over $1 million grant that we have that was approved. And I know that Florida Healthcare Association has been working on that grant since, I would say, last year, October, November is when they started on that, and making great strides, because they are required to report to us quarterly on the kind of deliverables on their status of that project. So again, I know last week at FDANA that Kristen Knapp and Debbie Franklin actually provided an overview of that. And Ian, what I will do is send you a link to our webpage for our civil monetary grants. So other folks that want to maybe look at some of these grants, some ways to, put some things in place to improve quality of care and quality of life, in your nursing homes. This is only available for nursing homes. I just want to make sure everybody understands that. But that is something that Ian, I can give you that link to our website, and you can send that out to the group as well. Make sure everybody has a copy of that. So
thank you, Kim.
Absolutely. So that's just, something about those. And, I do want to say, like you, Dr. Cepeda, I did listen to the president's address as my role as the president of our association, the Association for Health Facility Survey Agency Directors. I got a little heads up that was coming. So I think that we as state survey agency directors and you as providers are waiting just like we are. The only thing I got was a heads up that was coming out. But I have not received any more information on, the status of that. I think one of the things that folks want to know in Florida, because we have, House Bill 1239 that passed that, impacts staffing in nursing homes, but we also have CMS, that is, changing how they're changing the regulatory requirement for staffing in nursing homes. For years it's been, you got to have sufficient numbers to meet the patient need, to meet the resident needs. So now CMS is going to be, doing from my understanding, they do have some data, but going to be looking, at some data, maybe doing another quick study to see how they will break that down as far as, hours per day per patient. So I think we all are kind of waiting to see how they do that. I imagine that may be one of their initiatives that they roll out for implementation. The other couple initiatives, as you mentioned, may take a little while for implementation, but I think that one about, every nursing home provide that sufficient number of staff who are adequately trained to provide the care and services. I think that may be one of the first ones, but as soon as I hear information, I definitely will share that. Because again, as I keep saying, we are all in this together, and the more information we have and can work together collaboratively. We want to make sure our residents in our nursing homes and nationwide, that quality of care is improved, and that services are being provided according to their individualized plan of care. So thank you for allowing me to be here today. And I do want to say thank you to your group, Dr. Cepeda, for opening up the door and welcoming in also Dr. Scheppke with Department of Health. Our collaboration with our sister agency through this public health emergency has been so critical. And, we take our direction. They are the public health agency. We take our direction from Department of Health and have worked very closely with Department of Health, the Healthcare Associated Infection Team. And I know, as I tell all of our staff and all of our folks, staff in nursing homes, that when Department of Health comes in, the HAI team, they are there to help you. I know when ACA comes in, we're not coming in to help you, right? We can help a little bit, but we're not coming in with oh yeah, let's sit down and do some training. We're there to see if you're in compliance, but we want you to work closely with your HAI team. They are the experts. Matter of fact, I spoke to the HAI program director, Argentina Charles, yesterday, and we talk frequently. It's not we just run into each other every now and then. We have frequent communication because we both feel so passionate about our roles working together, to providing that education, us making sure you're following their recommendations, and again, both entities wanting to improve that quality of care along with you too, side by side with you. So thank you for your group for welcoming Dr. Scheppke, and he is just so fabulous to work with. I just do so much enjoy what he has to say and listen to every word, and again, thank you for the time, and thank you for the collaboration.
Thank you, Kim. Thank you. And I think we have Dr. Scheppke here actually a little bit earlier than I was anticipating, which I love. That's another thing I love, early. Shane, if you can make Dr. Scheppke a host, and Dr. Scheppke, I would love for you to come on so that you can introduce yourself to us. I know that you've spoken to us, to our group before, sort of randomly when we saw that you were on, we tagged you, but if you would please formally introduce yourself, we would love to have everybody aware.
Well, thanks so much. I appreciate the introduction, and I want to thank Kim also. Kim Smoak and I have been working together for quite some time, dating back from when we were stuck in that little closet we called the ESF 8 room in the Emergency Operations Center. So we got to know each other pretty well. Our two agencies do work very, very closely together. And first, let me start by saying thank you all for what you do every single day. You all take care of some of our highest risk population with COVID, and you've done monumental things to help you protect this group. And that's one of the things I want to talk to you about now today, is how we can go forward and continue to protect this group of folks. I know we did a great job with vaccinations and certainly with the infections and monoclonals. And as things evolve, I just wanted to bring everybody sort of up to speed on what we're thinking. I'm going to go ahead and share my screen, and just, if that's okay with you, and you can tell me if you see that screen okay or not. Can you guys see that?
We see it.
Great. So I want to quickly go over what we're looking at in terms of moving from pandemic footing to endemic footing. And certainly we know what a pandemic is. And we've all just lived through it for the last couple of years. This is when we have a new infection occurring worldwide. There's no immunity, there's no vaccines, there's no therapeutics, it's international. And pandemics, you move from pandemic to endemic when you've got these things. You've got widespread availability of vaccines, your population is largely immune, the infection rate and the death rates drop, and the community's risk tolerance to continue a pandemic footing sort of goes away. So there's a little political component to it as well. And I think we're getting close to that, and that's where the point of what I want to talk to a little bit about. And obviously, public health, we're going to continue to be there and be partners and we're going to continue to put our seniors first strategy and the populations at risk strategy. We're going to continue to do all that stuff, monitor diseases, monitor trends, continue to assist with vaccines and outpatient treatments, especially for underserved communities, and be that provider of last resort. From our partnership with you, though, with all the long-term care facilities, I just want to go over again, and I know many of you are already familiar with this stuff, but I think it's good to just review because it is sort of a moving target, the various treatment options, who they work for, what happens with resistance, with new variants, et cetera, and perhaps start getting everybody thinking in terms of how do you develop or how do you modify what we've been doing as we move into this sort of endemic role. So obviously vaccine boosters can continue to be a thing. You should all know already that a booster and perhaps even a fourth shot is currently recommended. I would expect in time to come that at least with the messenger RNA vaccines, that we will eventually be a little bit more like the flu, with like influenza, where there's a new vaccine every year, because the influenza virus is an RNA virus. RNA viruses tend to mutate so rapidly that last year's vaccine is no good anymore. Well, the coronavirus is also an RNA virus, just like influenza, but we've been fortunate that while, yes, it does mutate, it mutates at a much slower rate than what influenza does, which is why our vaccine from a couple of years ago still offers some benefit. But as you've seen, as the virus continues to mutate away from the original strain, the efficacy of the vaccine slowly is getting less and less, and as well as the immunity from the vaccine wanes over time, which is why these various boosters keep coming out. I suspect that the manufacturers, both Pfizer and Moderna, will eventually come out with a vaccine targeting a more recent version of the virus, and that will probably lead to improved efficacy again. So just keep on the lookout for that. It's certainly not something that's imminent, but that's just something I'm seeing in a longer term view of this. On the monoclonal antibodies, there are several flavors of this, and I think you all know I'm an enormous fan of monoclonal antibodies. This is something that has to be given to the patient very quickly, but these are kind of like a key fitting into a door lock. They are exact for the strain of the virus that you're dealing with, and if the virus changes the shape of that spike protein just a little bit, it can decrease the efficacy of our monoclonal antibodies. The two that we have in the state right now is sotrovimab and bebtelovimab. Both of these work for all prior variants, including Omicron. However, there's now a subvariant of Omicron you've probably heard about called the BA.2 subvariant of Omicron. And it does look like on cell studies, not in human beings, but on cell studies, sotrovimab may be losing some of its efficacy. However, bebtelovimab has continued to be efficacious, at least on the cell studies. So I think it's likely that the FDA will remove the emergency use authorization, like they've done with other monoclonals, when the BA.2 subvariant rises beyond a certain threshold, which we may see here in Florida in the coming weeks. So that really leaves us with one monoclonal antibody, at least in the foreseeable future, as we go forward, which is bebtelovimab. And that really needs to be given within the first 7 days of onset of infection. But the oral antivirals really offers us a lot of hope. Paxlovid is an antiviral that is highly efficacious. And it's also, the way it works, it's a protease inhibitor. And you may have heard that term before with HIV. We use protease inhibitors for HIV, and they're super effective. When a virus goes and copies itself, it creates a very long protein, and that protein needs to be chopped up into individual proteins that have specific jobs. It's a protease that does that. If the protease doesn't do that, then all you have is just a glob of amino acids that's non-functional, and the virus can't copy itself. So Paxlovid protects our cells by blocking the protease, which is basically a pair of scissors that would cut that long protein into all its subunit parts that would make that protein active. And it's going to be resistant to mutations because that protease is super well preserved. And the reason why it's super well preserved is because if you imagine, if you got a long protein that you have to chop at specific spots, if you mutate that protein, it's going to chop it at the wrong spot and you're going to get useless protein. So Paxlovid is going to, I predict, from a biochemical standpoint, remain efficacious despite the virus mutating. So this is what I really hope that you all have those of you that have pharmacies and you've got access to this. The downside of this medicine is that it gets metabolized in the liver and is affected by something called the cytochrome P450 system. I don't want to get too much in the weeds on this, but the point is many medications also go through that pathway in the liver. So Paxlovid interacts with lots of drugs. And a lot of the people that would need this are on medicines that would interfere with that. So you'll need to, in your pharmacy, you will need to get familiar with who you have to watch. You may have to take people off medications, and maybe people that they can't get this because of the medications that they're on. Molnupiravir works a little bit differently, and its efficacy is much lower. And I know that the demand has been a lot lower for that. It's literally only being considered the drug of last choice if you don't have anything else. And that's in recognition of two things. Number one is that its efficacy is much lower. And number two is that the way this works, it works by forcing the virus to mutate itself. And there's a concern there in terms of long-term safety studies. Is there a potential that could also cause our cells to mutate? And while I don't think so, that's something that sometimes shows up later on, which is why this is a sort of a drug that I've seen the demand be a lot lower for, understandably, because we've got much more effective medications. And here's the next one, which is really the point of this whole call, is Evusheld. Evusheld is a very long-acting pre-exposure prevention monoclonal antibody that I'm really hoping that your group, that your medical directors will take and run with, kind of like we did vaccines. I think that the utilization of this medication is way too low, and it's really the whole focus of what I want to talk to you about today. This antibody, and it's a combination of two antibodies, works on all variants, including the BA2 subvariant, which is really great. And it lasts in the body at least 6 months, perhaps as long as 12 months, and can be used for anybody in whom we think the vaccine doesn't work well, either because they are taking immunosuppressant medications, which many of your patients are taking, whether it be prednisone or cancer medications or autoimmune disease medications, et cetera, or even advanced age. My colleagues and I have actually done antibody studies on people getting vaccines, and we notice, and along with which is agreed to by other literature, folks over the age of 80 just do not mount a very robust immune response to vaccines. Well, you could supplement the vaccine program that you're using with Evusheld for people who are at high risk. So whether they're high risk because of their underlying illness, medications, or advanced age, this is something that we should be doing during the lull, where we are right now, before the next peak. Hit all these folks, 80 and older or younger than that, but with various comorbidities that put them at high risk. Give them the Evusheld, so that way when this next wave comes through, which will almost certainly be the BA2 variant wave, they'll be protected, and we'll be able to prevent these outbreaks in long-term care before it even starts. It's given as intramuscular shot, so it's a lot easier actually. It's not an intravenous infusion, but like the rest of them, you have to watch them for for an hour afterwards. So let's talk a little about what we're doing sort of right now, and the system that we've all been working on. And Kim's team has been fantastic. And as you know, those of you taking advantage of CDR Health, the state has a contract with CDR to send strike teams to long-term care facilities where there's been an outbreak. We were initially waiting for there to be a number of infections in the facility before we would activate the team. But I want to dial that back, because this is such a contagious virus now. It's literally as contagious as measles, which is one of the most contagious pathogens we have on the planet. And it hovers in the air. I mean, if you've got one case, I guarantee you're going to have other cases. So a single case, especially in congregate care settings like yours, should prompt a response where not only do you ask folks to go treat that initial case with either Paxlovid or bebtelovimab, one of the monoclonal antibodies, but also look at who is at risk in your facility who has not already been exposed. And while you have the experts there and you have the clinical staff there from a strike team, go ahead and get all those folks Evusheld to help prevent them from the outbreak from spread. Now, it's not used as post-exposure prophylaxis, meaning if you've got a roommate or somebody that you're next door to the index case, you can't give them the Evusheld. But if you got someone on another wing or a different building, use the opportunity to go ahead and expand that Evusheld because we know it's going to protect them as the next wave comes. But this is the system I have on the slide here is how we've been doing it. The cases identified, the information sent to ACA, ACA concept long-term care. We talk about the strike team or having long-term care pharmacy, et cetera. So I'm not going to read the whole slide for you. Suffice it to say that by the time we get to the point that CDR is going to dispatch someone, enough time has gone by that either you've taken care of yourself or it's old data and the patient's already recovered. And we're really not using this resource to the maximum benefit. So I'm going to propose a different way. And I think ACA is on board with this as well, that they're certainly there to help us all the time and they're wonderful partners. But like Kim mentioned, when we're talking about HAI team or strike teams, they don't actually have to be in the middleman position on this. If you have a positive case, I would love for you to have the ability to take care of this all on your own. But if you don't, pick up the phone and call CDR and tell them to send a team and do it immediately, because the more we wait, the more people will get infected. There'll be more hospitalizations, the more unneeded suffering. And CDR can come immediately to you, and they have the step that not only can give a normal monoclonal antibody like bebtelovimab, but they can do the Evusheld as well. Now, the problem with this is, this will work great. We can start that today, and there's the phone number for CDR. If you want to change your process, do it right now. But here's the problem. Our state contract ends with CDR on June 30th. That means you got basically a couple of months to develop some sort of self-sufficiency model within your own organization to do exactly what I'm talking about here. You've got a case, you need to treat that case right away, as well as make sure that you've reduced the risk to the other folks that live in that facility, either by Evusheld, vaccine booster, et cetera. So whether you've got long-term care pharmacy or you've got nurses that can study up on giving the intravenous infusion of the monoclonals, or even the IM shots of Evusheld, I think that's really, really going to be important as we move forward into more of an endemic footing, where the state's going to come back to our more traditional role, and then it's going to be the private healthcare system that takes care of this, just like we take care of all other illnesses such as influenza, et cetera, we deal with on a cyclical basis. I'm putting Shannon Hughes, who's in the room here with me right now. She's our project manager for COVID. That's her contact information. That feel free certainly to reach out if you got any questions, any concerns, think we can do something better to help you all out. We're happy to do everything we can, as you know. And with that, I'm going to turn it back over to you. I really appreciate the time that you've given me to speak to you today. And again, I can't thank you enough. I know these last couple of years have been really, really hard, and you've done enormous things really for the benefits of fluorines that you take care of. And thank you so much for that.
Thank you. And, I know our group is never really quiet. So do you have time for a few questions?
Absolutely. I'd be happy to stay for a minute.
Yeah, so anyone, if you have a question, please take yourself off of mute, or if you prefer, you can enter the question into the chat. I will, once again, just thank you. I have a question on the antivirals. What, some of our facilities have expressed concern on how to get those in, whether it is the distribution, I guess, is from the state, and what do we need to do, or how do we direct them and our long-term care pharmacies so that the medication is being distributed adequately to our facilities?
Do you want to answer it?
Sure. Hey, everybody, this is Shannon. I'd be happy to send you a link to the mailbox that is monitored daily. And what will happen is once you send, so I'll give you that mailbox link, but once a person sends an email to that, they get an auto response that is full of a lot of information and a lot of links, and it's specific to what kind of product you are interested in receiving. So I'd be glad to send that to you, Diane, if you want to share it with all of your
I would be so grateful. Yes, and then we can definitely distribute it to everyone who's on the call and even beyond. What about it for the Evusheld? I think the challenge for us is that we do have a staffing shortage. We do have that as an issue. And my concern would be that by the time we get access to the product, it is already in that post-exposure period. So what do we need to do to the point that you made, Dr. Scheppke, now? How do we get that into our buildings now?
Yeah, and that's a great point. And this is the time to do it while we're in the lull, because this is a preventative medication. It's a monoclonal also, but it is used, think of it almost as a vaccine substitute. So for people in whom the vaccine doesn't work well. So people over the age of 80, people who are immunosuppressive medications, they may be vaccinated, they may even be boosted, but we know they're not going to develop a really strong immune response. And we can give them this Evusheld, which is going to last 6 to 12 months to provide them that extra protection. So if you have people that are in that group, currently we have the contract with CDR, and we can send the folks with CDR out to give to your population. Obviously, there's limits to our bandwidth, so we'll do the best we can. And CDR does have, we did distribute to them some of the Evusheld, and we do have a contract with them up until June 30th. I mean, that contract, we only have a period of time available. After that, it's really going to go much more on, unless something else changes, back to sort of private sector healthcare system. So however you would normally do your vaccination programs, think of this sort of like vaccination program, because it is an intramuscular shot for the Evusheld. So the skill set is very, very similar to vaccine, except you give a couple of shots and then you'd have to watch it. The period of observation is a little longer because they like to watch it for an hour. Did you want to say something, China?
I was just going to say, in the long term, a lot of long-term care facilities in Florida, pharmacies do already have Evusheld. So one thing you could do is check and see. But in a lot of cases, like Dr. Scheppke was saying earlier, they're sitting on the shelf. People aren't that aware of these products, so you may find that they're already accessible to you.
Right.
That is a great point, and we always encourage our clinicians in the building, please check with your long-term care pharmacy consultants to make sure you have it. I think that's a great point.
And if they don't, they can order it.
Yeah.
Yeah, absolutely. The same way that you would order the Paxlovid, put in your request for Paxlovid. Currently, the model is the feds give to the Department of Health the whole state's allocation. And then we get requests from whoever wants it. Could be your group, could be pharmacies, could be doctors' offices. And then we collate those requests. And well, I say we, but I mean Shannon when I say that, collates those requests and distributes it in an equitable manner. So we certainly want to make sure we hit target populations that are at high risk, which you guys, you're at the top of the list for that. So we would make priority for you all.
And that's going to be through that link that I'm going to send to you, Diane.
Perfect. What is the turnaround time? So if I'm ordering something today, when will I expect it to be in my building?
We put the orders into the federal system on Friday afternoon, and typically the facility would receive it that next Tuesday.
And it's a weekly allocation for most things. The Evusheld, they give us a sort of supply that we draw down for the entire month. So it may be a little more efficient on Evusheld because it's a once a month thing. So when you put the request in, we can ask for it and they'll ship it directly from the feds to you.
Yeah, that is very good to know. I'm going to ask again, if anyone has any questions, please take yourself off on mute, or if you so want, you can enter into the chat. Thank you, Dr. Zorwitz, who put in an article about Evusheld from JAMA. So thank you for sharing that. Anyone with any questions? So,
hi, Diane. This is Terry O'Shea with Omnicare. Related to, and I lost connectivity for a minute, so I'm sorry if this was already answered, but regarding your question about oral antivirals, there is actually a new program the government has initiated. It's in its early weeks, but where long-term care pharmacies are able to directly order those now, not outside of the state allocation. So, that's at least something that's coming and should make them more widely available.
Thank you, Terry. You're absolutely correct. So if you have a pharmacy and the ability to test patients on site, you can fall under the Fed's new program. And they're working with, the idea is they want to give Paxlovid to places where a patient can go get tested, get a prescription, and receive the medication all at the same time, sort of like a one-stop shop. And then I would just simply say we should add monoclonal antibodies to that because not everybody can get the Paxlovid because of drug interactions. And then, of course, the protective, the population prevention method of Evusheld. So you're absolutely right. You can get direct allocations from the feds where you don't have to worry about us giving you a piece of Florida supply, although certainly, like I said, we would prioritize you for that. If you meet the criteria from the feds, you can get directly supplies from them as well as they move forward in that new program.
Dr. Scheppke, in thinking about as we're moving to endemic preparedness and getting stocked up on the medications we need, what do we need to do to further educate our staff who may not, I guess they're not in that population who would normally be getting the Evusheld? What education do we need to do to encourage them to get boosted or get vaccinated, as some of them are still not vaccinated?
Yeah, obviously vaccine is one of the frontline prevention strategies, and we have to recognize that every disease we deal with, you have a prevention strategy and a treatment strategy. And I think Florida, we've really been leaders on that, where I think a lot of nations can focus on prevention and mitigation strategies, where the treatment, which I did a lot to talk about today, is the other piece, because there is no prevention strategy that we've ever had prevents disease 100%. Even people who are vaccinated can get this disease and can transmit it to others and can get deathly ill. So for both of them, we're going to need everybody to do everything they can. We should not underestimate, number one, what we do not know about this disease in terms of long-term effects. I know we talk about deaths and hospitalizations. Perhaps we don't spend enough time talking about folks that have long COVID and these other disabilities that we're still learning about. And even young, healthy people like your staff, who may not be so much at risk for hospitalization and death, could potentially be at risk for some of these long COVID problems that we're seeing that even young, healthy people get. The vaccines do seem to prevent some of the long COVID symptoms. So I would definitely encourage folks who are eligible to get a vaccine or a booster to go ahead and get that. The idea behind the boosters is simply because the virus changes over time. So the vaccine was to the original virus. We're now on generation number 4 or 5 of this virus. So of course, the vaccine, you shouldn't expect to get the same efficacy level. And also over time, it's just natural for our bodies our immunity response to wane. So of course, you're gonna need boosters, just like you get a tetanus booster, right? Over time, things wane. This one just happens to be a tricky virus, so the immunity against the new variant wanes a little bit faster, which is why the boosters are so important, especially for the high-risk folks. But keep in mind, if you're somebody who cannot get the vaccine, which there are some people that have legitimate problems with the vaccine, even if you're otherwise young, Evusheld is something for you. Or if you're somebody where the vaccine, it may not be contraindicated in you because of allergy or something else, you can get the vaccine, but it won't work well. Vaccines for you, Evusheld's for you also. It gives you that same protection, relatively long amount of time. So I would definitely give both of those things, let people know that this is something that we're going to be living with for the foreseeable future. We'll have continued waves. And yes, natural immunity is a real thing, and vaccine immunity is a real thing. And but when you look at those two pathways, the natural immunity pathway comes with some risks that the vaccine doesn't have. The vaccine comes with some risks that the natural immunity doesn't have. But overall, I think most experts in the country agree that the vaccine-induced immunity is the safer path to travel down. So one of the messages that I work with a lot of firefighters, it's their decision how they want to handle this thing. Certainly it's their healthcare, but we're all going to have immunity to this thing one way or the other. And I think the pathway to that is either get infected or get the vaccine. And based on the literature, I believe the vaccine is the safer of the two paths. It's a decision that they need to make for themselves and discuss with their physician about. But I would certainly encourage them, especially healthcare work environment where you're going to be exposed to this thing. I think vaccine is a good choice. They also have to understand, no matter what they decide to choose on the prevention method, make sure they're aware of the treatment options, because these treatments don't just help them. it decreases the number of days that they're contagious. It helps the rest of society when we treat people. So if we put them on Paxlovid right away, it drops their viral load. We put them on one of the monoclonals, it drops their viral load. And now they're at less risk of infecting other people. So both strategies are really important, and we just need to make sure everybody has a knowledge base so they're ready to protect themselves as well as the people around them.
Thank you. And I thank you for bringing up long COVID. I think we've had a couple of talks around the state and country where we're trying to really make people aware of that, make people aware of the fact that we need to be more vigilant in addressing that and looking at that for our population. So I do thank you for bringing that up. And I know we had a question that came through, and I think it's directed at, actually it might be directed at Kim Smoak, about the fact that given all the clinical recommendations and changes that were proposed earlier and discussed earlier with the State of the Union information, will ACA support having certified medical directors in the long term in our nursing homes?
Well,
that's a loaded question, Kim.
That is a loaded question, but if you're talking about federal legislation, then that's not really for me to answer. That's not really for our agency to answer. That is, if there is language proposed to have medical directors, have certified medical directors in nursing homes, then we would all have an opportunity to comment on any federal language before it's adopted. So,
thank you.
What I do support is just like, and I think that we've had this conversation before, that a lot of people want to know, well, who is the medical director in that nursing home? And we post from a transparency standpoint, my contact information is out there. So why is a medical director's contact information for that nursing home that they are contracted with not available either? And just like we post nursing home administrators' names, we post a chief financial officer, we post their corporate affiliation, and everything about the facilities posted on, our website, on CMS 5 stores. So I do know that has been and continues to be discussions at the federal level as well. And I do know one of the things that CMS has recently said, that at some point it's, we may be talking, years down the road, who knows, but that they are looking at more, medical director requirements and how involved medical directors are in these quality issues that we're finding in our nursing homes, and folks who were at Verdana last week heard me mention the rise in immediate jeopardies and the quality of care, deficiencies, the high rise in quality of care deficiencies we're seeing. So that's something to kind of, prepare yourself for at some point, as CMS not only looking at, other things from the president's message, but other things CMS regulatory wise may be working on.
Thank you. I have a question for Dr. Scheppke, and Kim, this may also roll over to you. Given that we do have more availability of treatments now for COVID, if we see that it is not being given, how do we approach that? It's stating that maybe that's substandard care, I would imagine, but given that we have it available, if we're seeing it not being utilized, what do we need to do as leaders in our facilities, as the clinicians, and maybe as the medical directors in the building? What should we be doing?
Diane, I'm so happy you brought that up. And let me apologize. I don't know what's up with the camera that it doesn't zoom in. It looks like I'm like a mile away, but I see you all just fine. I think you're absolutely correct. Especially for the high-risk population that you're dealing with, if somebody has COVID, the standard of care really should be they get one of these treatments. Now, it's hard to say standard of care when you talk about medications that have emergency use authorizations. So maybe that doesn't yet apply, but I can tell you, if I have a family member in one of your facilities and they get this, I would expect that they're going to get Paxlovid if they're a candidate for that, or the bebtelovimab if they're not a candidate for the Paxlovid. And because we know that these medications are scientifically proven to decrease the rate of hospitalizations and death from this disease. whether vaccinated population or unvaccinated population, doesn't really matter. These medications clearly reduce your risk for this disease and should be considered almost a reflex. You get sick, you give them this. And then the larger thing should then enter as a secondary reflex is, okay, we got one case, who else has been exposed? Who do we have to start doing a little more frequent testing on? And who here needs Evusheld to protect them? But because it looks like we're getting a little outbreak in our congregate care setting. So you're absolutely right. We do unfortunately see some cases where by the time CDR, our strike teams get involved, nobody's been treated and everybody's either recovered or gone to the hospital already. And that's really something I'd love to see you all and the medical directors sort of do some sort of continuous quality improvement practice and perhaps an education program saying, all right, you had X number of positive cases this month or whatever. How many of them received treatment? For the ones that did not receive treatment, why was that? And really the only acceptable answer is that the patient or their guardian / family member decided for them to not get it for whatever reason they choose, right? Because it's certainly their choice, it's their body, but that should really be the only reason. It shouldn't be anything else. It shouldn't be that you didn't think of it or you didn't have a system in place to treat them. Those things need to be a thing of the past. We have a lot of options for therapeutics, and they're going to be more and more coming on board. We continue to hear about these new things in the pipeline that really look very promising. So we should all just be in the mode that we're going to continue the prevention strategies, do the boosters when indicated, but always be at the forefront of the treatment portions because we know prevention won't prevent 100%, and these folks are still at risk. And as long as you do early treatment, it saves lives.
Thank you. And I thank you again for joining us. I thank you for providing us with all this great information. Shannon, I look forward to getting that information from you. Kim, thank you for jumping on our call as well. And thank you for everyone who's here. We'll definitely send out some more information to you, and I want you guys to all have a great day.
Thank you so much for the time. I really appreciate the opportunity.
Thank you.
Thank you, Diane.
Thank you.
Diane.